Hey, everybody, welcome back to the Overrun on YouTube. Ed Bowder and Dan Schwester. We are here with Dr. Remle Crowe. We spoke about two of her papers on Tuesdays or on Monday's Journal Club. Dr. Crowe, thank you for joining us.
Thank you for having me.
And we've had Dr. Crowe on the show before, and we're so happy to have her back. I didn't give her a title because at this point it would almost take up the entire episode, I think. So ruler of all research that... ruler of all research that she surveys coming from Austin, Texas. So research commander. We can get you chevrons on your collar.
Kind of like, are we getting stickers or what?
Sure.
I mean, we're forming our own club. We're going to have to.
I guess so.
So we talked about these Airway studies, and we're talking about epidemiology. So if I'm in EMS and I'm interested in looking over research, Remle, what is your, I guess, give us some definitions. So talk to us about sample size and how that can affect a study.
Yeah. So sample size is one of the key considerations when I'm reading a research study and deciding how much should I believe this? How much weight should I give it? And that's commonly called the big N. What is the N of your study? People will ask, right? So there's no magic number, first of all, in terms of this is going to be a good study because it has this number of patients. But there are tables and formulas that actually help us pick how big of a sample do I need if I want to make estimates with 95% confidence and I'm willing to accept this amount of error. Now, good rule of thumb is if I see a study with 10 patients, do I think that those 10 patients reliably represent what's going on in this space? Probably not. Now, if I start to see thousands of patients, okay, now I'm starting to think that this study might generalize to other settings beyond the walls of the study itself. So that's really what we're looking at. When we're looking at sample size, we just want to know, is this a good enough group of patients that it probably represents what's happening in real practice? But it's not just about the sample size. And, we can dive into that if you want, or we can stop there. But sample size is definitely a key consideration, but it's not the only thing I'm looking at in terms of the sample.
Well, let's get into population too, because we want to talk about this paper about evidence-based guidelines for pre-hospital airway management. So talk to us about population for selection, then we'll start getting into the paper a little bit more.
Yeah, that is the second key consideration. So when we're looking at the sample, one of the big, and this one might even be more important than sample size, honestly, it's where did those subjects come from and do they represent the real world? And you've probably heard somebody, maybe you all have talked about this study that was in the BMJ looking at parachute use. And there was this randomized control trial done on whether or not parachutes work, right? Okay, sounds like we don't need an RCT, whatever. But they found 18 healthy volunteers to do this study. I do healthy in air quotes because like they opted to potentially jump out of a plane with a backpack full of air. But
we try
the joke goes on.
Throw unhealthy people off of airplanes.
I mean, you'd have to be pretty unhealthy to be like, randomize me to either a backpack full of air or a backpack with a parachute, like, and I'm going to jump out of a plane. I don't know. Right. But people did it. But the whole thing comes down to, if you check the appendix and you look at the picture, you see the plane was on the ground. So study setting and where it takes place and where that sample was recruited matter a lot. And that example sounds really funny, like, that's cute, but does it really actually happen in the real world in research? It absolutely does. A really important example is on the stroke screening instruments. So some of these scales that we've widely adopted immediately, we're like, yes, the RACE, the LAMS, all of these things, they were actually created, validated within stroke trials. So in studies where we knew the patient was having a stroke, we just wanted to see if they were having an LVO or not. And so then when we take that data out into the real world, where in the pre-hospital setting, when you don't know that somebody's for sure having a stroke, they can have a lot of things that look like a stroke. Those scales don't perform as well. And so that shouldn't be surprising to us. But they had huge sample sizes in these things, so we should absolutely believe it, right? Well, yes, but also we need to know where they got those patients from, and do those patients look like my setting?
And Dan, we talked about, if you've seen one study, you've seen one study, but I think Dr. Crowe made a really interesting point where if you don't know, like it's almost like people say, well, you can study anything, right? And you can adjust the results how you want. But I almost feel like people, because there's so much data available now, there's almost an over dilution where people will find studies that fit their bias. And then it starts to get involved into like medical policy. Is that, I don't think I'm off base with that, Dan.
Oh, sure. I think that happens frequently, and we love to anchor ourselves into a study that we love or somebody that we like who did the study or we look up to, and that kind of colors how we're going to perceive the study, and we don't look at it objectively. It's definitely a problem, and it's a pitfall for new clinicians who are getting into trying to study the nuts and bolts of why we're doing what we're doing or how we're proving what works or what doesn't work. It's very easy to fall into because people do we have really great people who do good studies, and then we find out down the road that didn't work out. I mean, one of the things I can talk about a while for when I first started getting into this stuff was early goal directed therapy for sepsis, where they loved this, and everybody I knew jumped on the bandwagon, and I was on the podcast, and I was listening to the show notes and doing the same thing everybody else was doing. And it turned out it didn't really work. We saw this more accelerated with the COVID outbreak when we were doing things and then we were looking at it or studying the data, and we were finding out it really wasn't working. But we like the people. Listen, we like to boost our people. We like to support people that we agree with or that we think are excellent providers or clinicians in their field. And we can anchor ourselves into these things and not look at it objectively for what it is. The other thing that I want to kind of throw to is a problem is, another big problem is reading abstracts, because you think you read an abstract and you think you've read the paper, and you haven't. You've read a tiny little snippet of something, and
Right.
maybe we could go into that just for new clinicians who are getting interested in reading studies, that you've got to go deeper, and you don't necessarily have to pay for it.
The abstract feels like this sizzle reel to me, right? Like you go into a movie and they show a trailer,
Mm-hmm.
and it's like, oh, they better not show the best scenes. And then like you'll go in and you'll read the paper and you're like, okay,
Absolutely.
yeah.
No, I absolutely agree with
And so,
that too.
Remle, is that a pitfall, that like a danger that people tend to fall into in your experience, where
Yeah,
they'll see
I
the
couldn't
abstract
agree
and like, yep,
more, honestly.
that's my Bible now.
Yeah, it's so tempting though. And I think you mentioned paying, and having the paywalls and the subscription services is sometimes a barrier to get to the full paper. But I would encourage people, one, don't necessarily pay to get access to that paper. Find somebody who has either academic library access, or email the authors themselves. The authors are very happy to send you their paper in most cases. And I think there's another barrier too to why people are a little bit nervous to read the whole paper. And that's that feeling of, oh, this is way above my head. Only Dr. Crowe, a statistician, could possibly understand that method section. And this is where I would say that's not quite right. Really, the better studies are the simplest ones. When they're using these big jargony words, that's when my spidey sense goes up a little bit and I look at it with a much more critical eye. So it's not that, oh, you're not capable of understanding this. Really, you should read it with a critical eye, and don't just trust it because it's published in a peer-reviewed journal or because this author was on it. It's worth taking a read, and everyone is capable of processing that information and saying, all right, how much weight should I give this? Am I going to take it into my practice? Should I wait? It's just one study, and one study is one study.
And we had Dr. Jamie Myers on a little while ago, and she explained that if you're just getting into reading data, some of the bigger studies will be announced in common media.
Oh, yeah.
Right. So, there'll be a news story about, today, like, we cured cancer today, which sounds like, a broad statement. And then you realize like, oh, it's because we found this, a gel that cures melanoma or whatever.
Do hamburgers actually kill you? More
exactly.
later on. But first, Dave, with the weather.
Right.
But that's also not helpful, because if I learn that 500 hamburgers will kill me, all I hear is that, so you're telling me is that $4.99 is the limit.
That's the limit.
I learned nothing from that. So Remle, you were one of the authors of this paper we talked about this week, going into evidence-based guidelines for pre-hospital airway management. And I wanted to talk to you about this article for a bit. We did go over it in the Journal Club yesterday. The link will be down in the show notes. But we wanted to talk about these tables because that's kind of really what we spoke about specifically. One of the things that kind of jumped out to us is over here where we see certainty of evidence, we see very low, 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 moderate, very low, etc. So just talk about that real quick, because it feels like maybe there's just not enough EMS data to really give us good information. And then I do want to get a little bit more into which airways work.
Yeah, I think that is one of the big takeaways from this project, really. So we came into this project with the idea of we're going to synthesize all of the data that's out there on pre-hospital airway management, and we're going to come up with some answers on what should we be doing. And then we did the systematic review and looked at the literature and found there's a lot of gaps and there's a lot of things that we don't know. And then when we do have studies on certain topics, it's often small samples, isolated settings. One system in EMS doesn't necessarily look like all the other systems in EMS. And we applied this process called GRADE, which is how you rate the reliability of a study. And it's a very specific methodology that you apply, and all of the reviewers on this project, and this is a real team project. I can't take any credit for it because you can see the huge group of authors, and we met so many times to go over this, but we really went through paper by paper on each of our study questions. And we said, all right, well, what is the quality of the evidence and what is the finding? And then should we build this into our recommendation? And you can see just scrolling through these tables, most of the certainty of evidence is either low or very low. And there aren't a ton of large randomized controlled trials in EMS and a ton of really strong evidence that we can lean on yet.
And that's a really important takeaway, right? Because it doesn't mean that the evidence is bad. It means we haven't done enough to study it. Like, all the recommendations, to be honest, my opinion from reading it seemed very common sense. It makes sense to me. It seems reasonable. It seems that somebody adopting these as a clinician would do a very good job for their patients if they worked under these parameters, right? But we just don't have the studies. We don't have anything to back it up. And I can talk about our home state, Ed. We pride ourselves, we're a tiered system, 2-medic program, we do RSI. The numbers that I've heard are pretty good. We actually do fairly well at it, but no one is putting that data out and no one is publishing it and saying, yes, statistically, we're doing this and here's the proof. So we can't specifically say that it works.
Well, and that's the problem, is that everyone ends up kind of appealing to anecdote after that, where, I mean, we talked about this earlier in the week, where like, well, yeah, the certainty of evidence might be low, but my certainty of evidence that I can nasally intubate somebody is very, very high. So that's what I'm going to do. And I think that's exactly, I've been doing this for 25 years.
Well, not even that. I've done this 10 times and 10 times it worked.
Yeah.
That doesn't mean anything. That means you've been really lucky.
So Remle, is this a more of a function of, I guess with the and again, evidence of absence is not absence of evidence is not evidence of absence, that kind of thing. Is the lack of research more of a function of, is it like operational? Is it availability of funds? Is it projects maybe aren't publishing their data that they have for whatever reason? They're not able to, or and I have to say there might be more nefarious reasons that maybe their data doesn't reflect what they want people to know. What, and I'm sure there's not one reason, but to your mind as a statistician, why aren't we getting this data?
Yes. First of all, all of those things.
One more.
No,
that's where we end the
I guess
episode.
we're good now, right? No, I think it's complex, right? So one is, even going back to like the 1996 Agenda for the Future, there was this call to have a cadre of trained researchers who come from EMS. And I think that's getting better, but this is still a call for all of us EMS clinicians, paramedics, EMTs, that we need to put value on and be involved in the research process. It's dangerous when we're not involved. So if, somebody who's never been in the back of an ambulance takes your EHR data and starts to apply it, they can come up with some really crazy conclusions. And I think that's one of the challenges with airway research is, how do we document airway? What are our definitions on these measures that matter? And is really the EHR the best place to get that? Might we use things like monitor data? Because, I mean, something as simple, first pass success. We talk about first pass success all the time, but what is first pass success and how do I know it's reliably documented? If I just poke in and go past the teeth and take a look, woo, was that an attempt? I'm not going to document that necessarily in my EHR. And who's there to verify
Right.
this, right? So there's challenges around the data quality and who's using it. I think that is a really important piece. And then to do trials, which is, traditionally the gold standard is to do a randomized controlled trial, because when it comes to airway in particular, there's so many other things that can be explaining the effect we see. And there's so many reasons why I might reach for an endotracheal tube, or in a different patient, I might reach for a supraglottic device. And without a random trial, it's very hard to rule out potential confounding variables or these other things that might explain what we're seeing. So I think to do these studies requires funding and researchers who have experience in the EMS space. And now there are some really good trials going on, and some that have already been published, like the PART study was a randomized cluster trial where we actually got an answer. So I think it's improving, but studies can be pretty slow, especially when it's an RCT. And, we just need more people who are engaging and in valuing and doing this kind of work.
And so going back to the airway control part, go ahead, Dan.
100% right. It takes time, it takes effort, and the timeline is longer than you think it is to do a paper. I was lucky. I had a great medical director at one of my old shops. We did a paper on bag valve masks, and it took 2 years. It was, by the time you got all the samples, you got the number of people, and you got the data, and you got somebody to look at the data and bring in a statistician that's an expert that can look at the numbers and tell us what the numbers mean, and then putting it together and submitting it for publication. This takes a long time. It does not happen overnight. It's not fast. And I think a lot of places don't look at that because I think in this profession, we're a very instant gratification profession. We like things happening now. We like things happening, and we like seeing results now. We love cardioversions. Why? Because when we do it, it works. When we defibrillate something,
adenosine's my favorite drug.
It's the reboot.
Yeah, and it's gone, and it's the reboot, right? And I think that's the mentality. And to develop this data over time, and then to look at outliers, and even something as simple like for monthly, like calculating your program's first pass success, you have to go through these reports, and you have to look at things, and you have to find outliers, and you have to say what works and what doesn't work. One of the things I can say about our state is we're very lucky that we have a data dictionary that they've actually put out. This is what this means. When we talk about an intubation attempt in our state, anytime a laryngoscope blade passes the incisors, that's an attempt. Doesn't matter what you do, doesn't matter where you go with it, that's the attempt. So some places do those things, but not a lot of people know that's there.
But then you'll also jump into providers who, they'll pass the laryngoscope once and then stay in there manipulating. And then it's like, oh, this is one attempt. And, the patient's been hypoxic for 45 seconds. Like, I agree that it's difficult to kind of gather the right kind of data that's going to directly reflect EMS. But along that line, we talked about these two airway papers, and with the data that we had available, it seemed to generally say for airway management, you have your BVM, your supraglottic, and your endotracheal tube. The BVM is probably better than the SGA, which is probably better than the endotracheal tube. So from the work you've done over the past couple of years on this with these papers, Remle, give us kind of like the idea of in your interpretation, what do you think the data shows is kind of the best airway device for certain events? And I understand there's no right answer, and this is a debate. But from what you've seen, what should we be doing? Fix EMS right now.
It's the one that your system can do proficiently and consistently. That was one of the really big arguments that we had during this, right? Was endotracheal tube is probably the best airway. However, there it's really difficult to maintain proficiency and be able to consistently place the tube appropriately. And so in systems where it's incredibly rare to place one, that might not be the best airway device, especially if you don't have the resources to constantly train and build preparedness for that event that is rare and high stakes, right? So in terms of that, I think that's one of the key takeaways in my eyes is your system has to be set up to produce the right results if you are going to do endotracheal intubation. And then in terms of those other devices, they're not without risk. It's easy to mess up BVM ventilation, right? And one of the things we didn't really have a ton of data on, there's almost no data out there, but the data that does exist points to mechanical ventilation as an important tool. We're not great with the BVM. Can we reliably apply mechanical ventilation in the right scenarios for the right patients? I think that question is going to become more important in the next couple of years. So even whatever we say today is subject to change, and I would keep my eye on that literature. But key is measuring this within your own system, looking for those adverse effects. And you mentioned a really important one. First pass success maybe isn't the measure I actually care about. Peri-intubation hypoxia, on the other hand, really is a measure I care about. So making sure that we're measuring what matters independent of which airway strategy we adopt within our organization.
And I think that's right. And I think certainly when it comes to, caring for the patient in general, I think it's more, and we talked about this again on Monday, it's better to have an airway and some semblance of airway control than to have a perfect airway. We're not throwing out the good in pursuit of the perfect. And, if you have a system that doesn't intubate very frequently, then it's something that you need to kind of look at and have, I guess, a little bit of humility within your system. Like, listen, our intubation success rate is 42%. We have to move on to something else. This data is important. It is growing. There is always an extant data set for airway management. But Dr. Remle Crowe, thank you so much for coming on and helping us clear this up a little bit. For the Overrun on YouTube, which you should subscribe to, there's a button down there. You got to push it and check out our show notes. And for the Overrun, I'm Ed Bowder.
And I'm Dan Schwester.
And we will talk to you next week.